Not all headaches actually start in your head. Kind of weird to think about, right? Sometimes the real problem is hiding out in your neck. Today we're going to dive into two conditions that are famous for this and get mixed up all the time: cervicogenic headache and occipital neuralgia. Let's figure out what they are and, more importantly, how you can tell them apart.
So let's just start with the big question right up front. Could that nagging, persistent headache you're dealing with actually be a message from your neck? It's a super important question because, trust me, getting the answer right changes absolutely everything about how you treat it. Okay, to solve this little medical mystery, we need to get to know our two main suspects. First, you've got cervicogenic headache, we'll just call it CEH, and then you have occipital neuralgia, or ON. Now, they might look similar on the surface, but deep down, they're fundamentally different beasts.
So first step is cervicogenic headache. The name itself is a huge clue. Cervico means neck, and genic means originating from. See? This is what we call a secondary headache, which just means it's a symptom of another problem. In this case, something in the neck, like an irritated joint. The pain almost always starts in the back and then creeps its way forward, usually sticking to just one side of your head.
Now let's meet occipital neuralgia. This one is all about the nerves. It causes these really sudden, sharp, almost electric shock-like pains that shoot along the path of the occipital nerves, running up the back of your scalp. It's a very, very distinct feeling.
And here, this picture shows you exactly what we're talking about. You can see those greater and lesser occipital nerves branching out from the top of the spine and spreading out across the scalp. For both of these conditions, you can think of these nerves as the superhighways that carry those pain signals from the neck right up into the head.
Okay, so if you remember one thing, make it this. Here's the key difference. Think of a cervicogenic headache as a faulty alarm. The wiring, the nerve, is fine. The problem is that something else, like an irritated joint in your neck, is constantly setting off the pain alarm. That's called nociceptive pain. Occipital neuralgia, on the other hand, is a faulty wire. The problem is the nerve itself. It's damaged or irritated and is sending out its own pain signals. That's neuropathic pain. So, faulty alarm versus a faulty wire. It's a simple way to think about it, but it makes all the difference.
So, how in the world do doctors tell these two apart? Well, it's kind of like a medical investigation. They have to look for specific clues in what the patient tells them and what they find during a physical exam. And the very first clue is always about the pain itself.
With CEH, people usually describe this nagging, dull ache that doesn't throb, and it can stick around for hours, sometimes even days. But with OM, it's the total opposite. We're talking short, sharp, intense attacks of shooting pain that are over in just a few seconds or minutes. Two totally different experiences.
So when a doctor suspects CAH, here's the checklist they're running through. Does the pain start in the neck and travel forward? Yep. Does it get worse when you move your neck a certain way or when the doctor presses on specific spots? Check. Is your neck stiff? Usually. And sometimes you might get some mild migraine-like stuff, but that's not the main feature.
Now, for occipital neuralgia, the clues are really fascinating. The pain follows that exact nerve pathway we saw earlier. The scalp can get so sensitive that even just a light touch hurts. There's a medical term for that. It's allodynia. And here's the biggest clue of all. A doctor can do a nerve block with some local anesthetic, and if the pain just stops, well, that's a pretty clear sign the nerve is the source of the problem.
And one of the biggest mix-ups is between CEH and migraines. This slide lays it out so clearly. CEH starts in the back. It's a dull ache, and you can actually trigger it by moving your neck. A migraine? That often starts up front. It has that classic, horrible throbbing quality, and moving your neck doesn't really have anything to do with it.
All right, so we've played detective, we've looked at the clues, and we have a diagnosis. Now it's time to open up the treatment playbook. And this is where getting that diagnosis right is absolutely critical, because the strategies for each one are very, very different.
For both conditions, you almost always start with what we call conservative treatments. This is the first line of defense. We're talking about things like physical therapy to help with posture and muscle tension, learning about the pain, maybe some medications, and even cool little devices like a TENS unit, which uses a mild electrical current to help manage the pain.
But what happens when those first-line options just aren't cutting it? When the relief isn't enough? Well, that's when you move into the world of interventional pain medicine, which uses really precise, targeted procedures to get right to the source of the pain.
So let's take a look at these advanced pathways. And these aren't just random guesses. These are evidence-based, step-by-step plans that are designed to give the most effective, long-term relief possible, perfectly tailored to the specific diagnosis.
For CEH, remember, that's our faulty alarm. The pathway is super clear. First, the doctor confirms that the facet joints are the problem. Then they do a diagnostic block to see if numbing those joints helps. If the patient says, wow, my pain is at least 50% better, then the next step is often a radiofrequency procedure to give much longer-lasting relief. It basically quiets down the little nerves that supply that joint.
Now, for ON, our faulty wire, the plan targets the nerve directly. So after conservative treatments don't work, a nerve block is done. If that helps temporarily but doesn't last, the next step is often something called pulsed radiofrequency, or PRF, right on the nerve itself. And for the really tough, stubborn cases, there's even a treatment called occipital nerve stimulation.
And honestly, this quote from the research paper we're looking at just sums the whole thing up perfectly. For cervicogenic headache, you treat the joints. For occipital neuralgia, you treat the nerves. Two different problems, two very different, highly targeted solutions. It's really that clear.
So we end up right back where we started, but this time we have an answer. Figuring out the true origin of your headache isn't just a fun fact, it's the absolute key. Getting the right diagnosis, knowing if you're dealing with a faulty alarm or a faulty wire, might just be the thing that finally unlocks a whole new path to real, lasting relief.